It's live now.
All right. So
good evening, doctor.
Good evening.
You can start your webinar now.
All right. Thank you. Good evening, everyone. I am Dr. Kanwaljit Singh. I'm a consultant pulmonologist at Indus International Hospital, Derabasi. I'm also practicing at Indus Hospital, Mohali from the past 3 years. So today we will be discussing about the role of omalizumab in severe allergic asthma. Light is not going forward. So these are the outline of the topics what we are discussing today. So we will be discussing about the asthma first, then we will be discussing about omalizumab in detail. So what are the common allergy conditions that we see in our daily practice? So this includes allergic asthma, urticaria, allergic rhinitis, allergic conjunctivitis, allergic rhinoconjunctivitis, atopic dermatitis, allergic contact eczema, allergic urticaria and angioedema, food allergy, and anaphylaxis. But we will be discussing in detail about allergic asthma. So as you already know, this is our respiratory system. It includes upper respiratory system and it is divided into lower respiratory system as well. So up to the larynx is upper respiratory system, which includes nasal cavity, pharynx, vocal cords, and the larynx. Below which starts trachea and bronchus, and then the primary bronchus, secondary bronchus, and it divides tertiary bronchus, terminal bronchioles, respiratory bronchioles, and into the alveoli. So these are the parts of the tracheobronchial tree. So this is the airway structure in cross section. So the outer layer is smooth muscle layer, then inside is spongy layer, and the inner layer is epithelial layer. So what is asthma? In normal, here you can see on the left side is normal airway, and in the middle is asthmatic airway, which is swollen and inflamed and thickened. And on the extreme right is the asthmatic airway during the attack, which leads to severe narrowing of the airways and leads to decrease in the air entry. So during asthma, airway becomes smaller and narrower due to the underlying inflammation and swelling, and it is also due to the increased mucus production and contraction of the muscles around the airways, which is also called bronchospasm. So asthma is a disease of airway hyperresponsiveness, and which leads to a bronchospasm, and it is a chronic inflammatory disease. So what is the prevalence of asthma? So globally, around 358.2 million people suffer from asthma, and in India, 32.3 million people suffer from asthma. So the contribution of India in the global asthmatic patients is 11.1%. So India ranks second in the asthma prevalence. So in mortality, India is #1. So what are the common symptoms which we deal in the OPD of asthma patients? If patients present with chronic coughing that is uncontrolled with the use of various medications, then you have to suspect asthma. Second is wheezing. Not all patients present with wheezing. When the symptoms get worse, then only you have this wheezing. Patient also complains of chest tightness or congestion, and when there is severe bronchospasm, then patient also complains of breathlessness. So this breathlessness is on and off, and it decreases on its own and it worsens on its own. So these are the symptoms which a patient complains to you when he comes to your OPD. So how is the diagnosis made of asthma? First, we have to take detailed history about the symptoms of the patients, about seasonal and diurnal variation, and then you have to ask about the family history, activity limitation, and if patient is using the reliever medication, if patient feels relieved after using inhalers or DPIs, then that is also important. Then you have to check the lung function test, which includes the spirometry. It also includes bronchodilator reversibility test. Then in the physical examination, you have to auscultate for any rhonchi in the chest. So how is diagnosis and monitoring of the asthma is done? Clinically, there is a asthma control test, which is also available online, which can a patient do himself or herself. Then physiologically, diagnosis is made by spirometry or deflowmeter. So biologically, we check the serum eosinophil levels or fractional exhaled nitric oxide, that is also called FeNO. So in the bronchodilator reversibility test, if the force expiratory volume, that is FEV1 in 1 second, increases by 12% or 200 ml after giving the bronchodilator, then it is labeled as asthma. So what is the definition of allergy? Allergy occurs when your immune system overreacts to an allergen, something that usually is harmless, such as plant pollen, dust mites, molds, insect stings, or food. So it is divided into asthma is divided into allergic and non-allergic. In non-allergic individuals, allergen stimulates. Uh, allergen. Excuse me. How do we? Excuse me. How do we remove this upper bar? I'm not able to see the slide fully.
Sorry, doctor.
This upper bar is hindering the view of the slide. Is there any way to remove this upper bar?
No.
Okay.
I think it will come like this.
Okay. So I will continue. So in non-allergic individuals, what happens when allergens enter into the body? Allergen stimulates the production of IgE, but the IgE level is equal to the allergen. So the allergen is neutralized by the IgE or it is destroyed. So in what happens in allergic individuals, allergen stimulates the excess production of IgE. So in allergic individuals, IgE level is more than the allergen level. So some of the IgE neutralize the allergens, the rest of the IgE cause allergic reactions by binding to the mast cell and leads to the release of histamine. So what are the common triggers for allergy? Pollen from plants, animal dander, dust mite, dust from household, and cold air, mold or fungus in damp walls, smoke and cigarette smoking. So this is the pathophysiology of the allergic reaction. So allergen enters the body, it produces IgE antibodies, antibodies bind to the allergens and leads to the sensitization of mast cells. The excess antibodies bind to the mast cell but doesn't lead to the release of histamine at first exposure. Then in the second exposure, there is an early allergic response and late allergic response. In early allergic response happens within 5 to 10 minutes after the exposure to the allergen, which happens due to the release of histamine by the mast cells, and later migration and activation of neutrophils and eosinophils happens, which leads to the release of secondary mediators, and later it leads to inflammation, bronchoconstriction, increased mucus production, decreased ciliary activity, and vasodilation. So this late response happens between 3 to 11 hours after the exposure. So what is the pathogenesis of asthma? So trigger or allergen comes into the body, IgE is released and interleukins are released, which leads to bronchospasm, and inflammation of the airways. So in allergic asthma, the causative factor is IgE. In non-allergic individuals, uh, eosinophils and interleukins play important role in the asthma attack. So this is a chart showing differences between allergic and non-allergic individuals. In allergic individuals, age of onset is younger than the non-allergic individuals. So allergic trigger is there in allergic patients. Seasonal symptoms are more marked in than in non-allergic patients. Food allergy is also more common in allergic asthma patients. Nasal polyps are more common in non-allergic patients. So this you have to remember the difference. So family history is more common in allergic individuals. Smoking history is more common in non-allergic individuals. So decrease in FEV1 less than 80% is more common in non-allergic individuals. So there are various guidelines available online for the asthma management. This includes the GINA guidelines that is mostly followed everywhere. There are guidelines by British Thoracic Society, by National Asthma Education and Prevention Program, by Canadian Thoracic Society, by Indian Chest Society, or NCCP. So what is a pharmacological management? It includes use of two drugs, which is reliever and another one is controller. So reliever are the bronchodilators, which acts on the airways to immediately relieve of the bronchospasm. So it quickly relieves the symptoms, and the duration of action is faster and duration of action is also short. So the controller medications are inhaled corticosteroids. These include decrease the inflammation in the airways, and it prevents the further asthma attacks. Onset of action is slower and the duration of action is longer. Bronchodilators, that is SABA or formoterol, is used as a rescue medicine, and inhaled corticosteroids are used as regular medicine. So this is a chart showing the steps of asthma management. In step 1 and 2, we use inhaled corticosteroid plus formoterol according to the latest guidelines. And in step 3, we use low dose maintenance ICS plus formoterol. And in step 4, we upgrade to the medium dose. And still, if uncontrolled, we add on long-acting antimuscarinic agent. So, or we can send the, if patient is still not controlled, then we have to send the patient for phenotypic assessment. And then we can add the biologicals if the asthma is still not controlled. First, we have to add on the LAMA, then the oral corticosteroids. Then we have to go for the phenotypic assessment and use of biologicals. So identifying, how do we identify the severe asthma patients? So uncontrolled asthma patients include 25% of the total patients. It includes poor symptom control as well as frequent exacerbations. So there is also a term called difficult to treat asthma, which also includes severe asthma. So what we call difficult to treat asthma, if the patient is symptoms are uncontrolled despite step 4 and 5 of the treatment, and despite giving the maximum inhaled corticosteroids plus the use of 2 bronchodilators, and patient is still not relieved of the symptoms, then we label the patient as difficult to treat asthma. But if the patient is having symptoms despite adequate adherence to the treatment and using adequate technique for the inhalers, and despite treating the comorbidities, then it falls into the category of severe asthma. So what are the biological therapy used for severe asthma patients? That is stage 5 of the GINA recommendation, what we discussed earlier. So these are the biologicals, list of biologicals given. So omalizumab is the one which targets IgE in the body. and the mepolizumab and relizumab, reslizumab targets IL-5, and dupilumab targets IL-4. This is the comparison chart of these various biologicals. So among these, omalizumab targets IgE, mepolizumab is IL-5, reslizumab IL-5, and benralizumab acts on the IL-5 receptors. Dupilumab acts against IL-4. Only reslizumab is there in the chart, which is given IV infusion. Rest all are given as subcutaneous. So how do we select the biological therapy? So in the patients, if the patient is eligible for anti-IgE therapy, we have to do the sensitization of skin prick test or the specific IgE levels. Then we do the total serum IgE levels and weight of the patient, and we have to check the exacerbation in the last years. So what are the factors that may predict good response to anti-IgE, that is omalizumab? If the patient is having blood eosinophil levels more than 260, FeNO levels more than 20 ppb, and the patient is having allergen-driven symptoms, or patient is having childhood onset asthma, then omalizumab response is better. If the patient is having more exacerbation in the last year and blood eosinophil level is more than 300, then the patient benefits more from anti-IL-5 therapy. So what are the factors that may predict good response to anti-IL-5 therapy? That is higher blood eosinophil counts, more exacerbation in the previous year, adult onset asthma, and patients having nasal polyposis. So what do we have to consider before starting the omalizumab therapy? First, we have to do the allergy testing, that is skin prick test or the specific IgE levels. And we have to check for total serum IgE levels. We ask the patient to do asthma control questionnaire to categorize and to check for the future asthma control. Then we do a spirometry for future lung function testing also for the comparison. So what is omalizumab? Omalizumab is humanized monoclonal IgE antibodies. It binds to the IgE at receptor binding domain and form a complex, and which prevents the attachment of IgE to mast cells, and hence it prevents the allergic cascade. So this is the mechanism of action of omalizumab. It binds to the free IgE, decreasing the cell-bound total IgE levels. So later on, it decreases the expression of high affinity receptors, and which leads to the decrease of mediator release, that is histamine, and which later on decreases the allergic inflammation, and it prevents the exacerbation of asthma, and it reduces the asthma symptoms as well. So I'm skipping this slide. This is the algorithm for biological therapy selection for asthma patients in severe asthma. So if the patient is having uncontrolled asthma symptoms or exacerbations, then first what you have to do is confirm the inhaler compliance and technique, and also identify and avoid the triggers, and you have also to treat the comorbidities which can mimic the asthma symptoms. So then you have to check the FeNO levels, blood eosinophil levels, and the total IgE levels. If the patient is having corticosteroid dependent asthma, then benralizumab, dupilumab, or mepolizumab benefit more. If no, then you have to take the history of allergy-driven uncontrolled asthma. If the patient is having allergic asthma, then you have to use omalizumab. If no, then you have to check the FeNO levels. If FeNO levels is more than 20, then go for dupilumab, omalizumab, and tezepelumab. If FeNO level is less than 20, then go for blood eosinophil levels. If eosinophil levels more than 150, then benralizumab, dupilumab, mepolizumab, omalizumab, reslizumab, and tezepelumab benefit more. If eosinophil levels are less than 150, then mepolizumab and tezepelumab benefit more. So in special conditions, we can consider the use of various biologicals like in nasal polyposis. Dupilumab, mepolizumab, omalizumab benefit more in atopic dermatitis patients. We can use dupilumab. And in eosinophil granulomatosis with polyangiitis, we can use mepolizumab. In hypereosinophilic syndrome patients, mepolizumab is used. So these is the flow chart showing various studies that that were done for the omalizumab. So there was a stellar study done for the omalizumab. Its objective was to determine the importance of pre-treatment blood eosinophil count and for the predictive measure for response to omalizumab. It includes 872 patients of severe allergic asthma. So having blood eosinophil counts more than 300, there were 52%, 52.1% of the total individuals that had eosinophil count of more than 300. So what were the outcomes of this study was the combined response rate was 58.4% for blood eosinophils more than 300 and 58.1% for blood eosinophils less than 300. So omalizumab is effective. Effectiveness is similar in both high and low eosinophil group. So in 49.2% complete continuation of OCS therapy was observed of patients with severe allergic asthma, and OCS dose was reduced to half in 61.2% of the patients. So this was another study published for the efficacy, showing efficacy and safety of omalizumab treatment. It was a 16-year-long follow-up study. So no systemic, what were the outcomes of this study? That no omalizumab, no systemic or local adverse effects of the omalizumab were seen. No issues related to immunological pathologies or infections were seen. Clinically efficacy maintained over a very long interval. So what are the clinical benefits of omalizumab? It decreases the inflammation of the airways in asthmatic patients, and it decreases the number of exacerbations, and also decreases the number of hospitalizations, and also decreases the use of rescue medicines in asthma, allergic asthma patients, hence leading to increase in quality of life and lung function. So there was another study comparing amzumab versus innovator omalizumab. Amzumab is a biosimilar of omalizumab. So it was a randomized double-blind controlled study. So its objective was to compare the efficacy and safety of amzumab versus Xolair in patients with moderate to severe persistent asthma. So it was divided into two groups. First one was the amzumab group, and second one was the Xolair group. 69 patients were included in the amzumab group and 35 in Xolair group. So treatments were done with 150 to 375 milligram of amzumab or Xolair in every 2 weeks or 4 weeks as per the dosing of the depending upon the level of IgE and weight of the patients. Duration was 16 weeks. So the results were comparable, that number of exacerbation was 5.8% in amzumab versus 2.9% in Xolair group. And number of patients with at least one exacerbation were 4.4 in amzumab, and Xolair was 2.29%. And number of exacerbation requiring hospitalization was 0% in amzumab versus 2.9% in Xolair group. And the secondary outcome at week 16, the proportion of subjects with mean change in overall asthma control questionnaire score and proportion of responders based on global evaluation of treatment effectiveness assessment was similar at 16 weeks. The mean change from baseline in FEV1 was also similar in both the arms. So if we compare side by side, the innovator is Xolair and biosimilar is amzumab. So total number of adverse effects were 39 in Xolair group and 63 in biosimilar group, that is Emzumab. At least one treatment emergent adverse event was seen in 51.43% versus 38.57%. And severe adverse effects were seen in one in each group, one patient in each group, and there were no reported deaths. And treatment was discontinued in one patient in Xolair group, and immunogenicity is seen in none of the patients in both groups. So the conclusion is biosimilar to omalizumab and reference product were comparable in efficacy, safety, biosimilarity characterization, including the immunogenicity. So no clinically meaningful differences were seen in biosimilar omalizumab with the reference product. Now this is the Emzumab biosimilar of omalizumab introduced by Cipla. So it comes in a packing of 150 mg. So what are the key features of Emzumab? It is a world's first biosimilar of omalizumab. It works biologically the same as omalizumab. That is why it is called as biosimilar. So it significantly reduced the severe allergic asthma exacerbations and hospitalization and the use of oral corticosteroids. It is similar in efficacy to the innovator omalizumab, and it is clinically proven safe. It is given subcutaneously, and it is stored at 2 to 8 degrees centigrade. So what are the black box warnings? Presenting mostly the patient does not report any adverse events, but in rare cases, patient can present as bronchospasm, having hypotension, syncope, urticaria, angioedema of the throat or tongue, who have severe anaphylaxis. So occurred as early as after the first dose, but also can occur beyond 1 year after beginning regularly administered treatment. Healthcare providers should be prepared to manage anaphylaxis, which can be life-threatening. So it can be, it should be given in the proper setup where backup is there in case you have to prevent the anaphylaxis, and if in case you have to treat the anaphylaxis. So what are the other minor side effects? Injection site reactions, arthralgia, pain, leg pain, fatigue, dizziness, fracture, arm pain, pruritus, dermatitis. What are the therapeutic indications of Emzumab or omalizumab? Adult patients with moderate to severe persistent asthma and positive skin test or in vitro reactivity to perennial aeroallergen. So this is the dosing chart. It is based on the total IgE levels and the weight. So maximum dose given, which can be given, is 375 mg, not beyond that. And IgE levels should be checked at before starting the treatment, and IgE levels should not be repeated during the course of treatment. So what are the key highlights for Emzumab? Over 20 years of clinical experience with omalizumab, both clinical trials and real-life evidence for long-term use of omalizumab. Similar clinical benefit with high or low eosinophil counts. Emzumab is the world's first omalizumab biosimilar, and Indian studies have shown efficacy and safety of omalizumab or Emzumab. So it has a faster response to therapy. It approximately takes around 4 months to show its effect. And Emzumab is the most economical of the available biological therapies. Thank you so much.
Thank you, Doctor, for the wonderful presentation. We have questions in the chat box.
Okay. Is there any question? I cannot see any question right now. If anyone having any question or any doubt, you can ask me.
Okay, the first question is, Please elaborate on safety consideration with the use of IgE inhibitors.
Pardon? I didn't get. Can you repeat the question, please?
Please elaborate on safety considerations with the use of IgE inhibitors.
IgE inhabitants.
Inhibitors.
Habiters. I
Hello.
have. Hello. Yes. Hello. Yes. I have been using omalizumab for the past 3 years in patients having high IgE levels, presenting with severe asthma symptoms and multiple exacerbations. So, as per the safety, I have rarely seen any minor side effects also. So most of the time it is safe. I have not seen any anaphylaxis in the patients. One of the most common side effect which patient complains is the site or pain at the site of injection or minor swelling, and which later on subsides by itself. That's all. So it is a very safe biological therapy which can be used as a life-saving for patients with severe asthma.
One more. What are the main contradictions of omalizumab?
Patients who have allergy to omalizumab, allergic, in those patients we cannot use such. Means we have first have to give the test dose of the patient. Then if the patient shows allergic reactions, then we don't have to use this omalizumab. The second one is if the patient is having low IgE levels in the normal range, then we don't use omalizumab. There is no use of omalizumab in patients with having low IgE levels. That are the more, two common contraindications. Minor side effects can be ignored.
How do you manage an asymptomatic patient with being chronic eosinophilia?
Chronic
Chronic eosinophilia.
eosinophilic failure? I didn't get you.
Yes, being chronic eosinophilia.
Chronic eosinophilia.
Yes, sir.
Okay. So chronic eosinophilia patients are mostly managed with the steroids. There is no role, as far as I know, there is no role of omalizumab in that. So those are the patients which respond better to the steroids.
Sir, how do you see the future of omalizumab in the management of allergic asthma?
So, as I told you earlier, that I have been using it for the past 3 years, and I have seen wonderful results. Those patients who end up landing in emergency frequently after every 1 to 2 months, they have stopped having any exacerbations after using the omalizumab. There are many patients who are still coming for the omalizumab injection on follow-up, but after I started the omalizumab, I haven't seen any exacerbation among those patients. So omalizumab has a wonderful future. If the main issue is the cost, some patients are not affording. That is the main issue. Otherwise, if the patient with severe allergic asthma can afford it, then it is a wonderful drug. It can also reduce the dose of inhaled corticosteroids also.
Thank you, sir. What are the monoclonal IgE antibodies in clinical trials currently?
I'm sorry, I'm not aware of that.
Okay. Thank you, sir, for the wonderful presentation and for your valuable time. We may
Thank
now
you.
end the session. Thank you.
Okay. Thank you so much for participating. Thank you, everyone.